Fellowship programs or younger consultants who are still in a spectrum who can actually join some fellowships. So without further any delay, we will start with the first talk, postdoctoral training, glory or necessity. Dr. Khochikar is with us on virtual platform. We'll hand it over to him.
Yeah, thank you, Abhishek. Thank you, Ashwin. Thank you, Sabnis. It's wonderful to be here in this youth conclave. And I think it's an interesting topic which is given to me, postdoctoral training, glory or necessity. Life is all about perception. And I think it's all for your eyes only. That's what I believe. I believe Abhishek has asked me because I've done a super specialty, a subspecialty within the super specialty, and probably he must have asked it. So I assume that. So just look at from my experience itself. When I did my national board in urology many years ago, it was really necessity. I went to UK for further training in diploma urology. I did it. I did sort of an emphasis urology, FIBU. And I think for me, it was necessity. And for my peers and my friends, they thought it's more of a glory. But unless you achieve something, unless you do something, and you specialize, I don't think you can achieve a glory. And I think the proof is in the pudding. Over the period of time, you subspecialize, you do something extraordinary work, and then probably the accolades are going to be there. Previously, we used to think, whether you have your social websites or, social platforms, is it necessary or is it glory? I think it's more of a necessity itself. We built this hospital in 1998, Siddhivinayak Ganpati Cancer Hospital. It was a dream. We wanted to have some specialty in cancer itself. This was a necessity. But look at many years down the line. I think you progress into this specialty, and then probably it will become more of a glory rather than a necessity. And the times have changed now. Apart from specialty, you require people to come together and have super specialty hospitals with multidisciplinary times. And this is how, at times when you think it is going to be something like a glory you are aspiring for, but it's not. It's basically the necessity which actually leads to pursue that kind of specialty, which ultimately would lead to glory itself. A lot of people contradict and say urology itself is a super specialty. So why do you have to go for a training? Yes, I agree, but I'm sure you all agree, we can't do justice to each and every aspect of urology, even though we are specialized in this branch. For example, you take transplantation. You get a rotation in your MCH training program or DNB program for a transplantation. You may spend about 2 months or 3 months in transplantation. But if you want to make a career, you want to specialize yourself, you want to contribute to this specialty, I think you require substantial time into this sort of specialty. It is just not the technique you are learning, but I think the whole science of transplantation, the nephrology, the complications, everything you need to learn. I can't overemphasize about oncology, and I'm going to explain you in my talk. I think just doing radical nephrectomies or taking small tumors out to the TURBTs doesn't make you a urological oncologist. It's a wide spectrum of specialty. You need to understand the science better. Same holds true for pediatric and neonatal urology. How many of you have been given a sick child with reflux and all other congenital malformations, how you are able to deliver a proper care? And same applies true for complex reconstructive urology, failed hypospadias, failed reconstructions, post-radiation complications. I think you require proper training, specialty within the specialty, and for that you require skill, in-depth knowledge, specialized care, support system, and then we'll have a better outcome itself. I must give you sort of a background where the subspecialty started in India, and I must say, this is way back in 1986 when I got trained. Dr. Phadke was trained in USA and Canada, and he brought this concept of subspecialty within the super specialty, and at that time it was a necessity. And I'm sure with the period of time, it has glorified into this subspecialty. Credit goes to Dr. Phadke, my mentor. He converted Bombay Hospital into teaching subspecialties because that time, even in 8085, we had a urodynamics, we had pediatric urology, we had uro-oncology, you had andrology as a subspecialties within urology itself. Coming to my subspecialty, I'm going to cover a few areas which will highlight the need of subspecialty training within the urology. I'm sure a lot of people do nephron sparing surgery, but you get the endophytic tumor, solitary kidneys. Doing once in a while is not something important, but why this patient has a cancer? What's the further treatment? Can you do something different? Can be very well learned if you have enough time to be spent within the subspecialty. Doing a good job is extremely important for that patient as well as the final outcome. Now, complex cases can be done like IVC thrombus and all those things, provided you have spent enough time within the subspecialty itself. IVC thrombus, you need cardiac surgery setups, you need intensive care unit, and you can deliver this sort of care. Because I personally feel that if you're called as a super specialty, I think you should be able to give all that kind of care within your specialty. That gives you sort of deal with the complex situations like these, bleeding angiomyolipomas. Many times I see in my practice, patients, urologists take the tumor out, testicular tumor out, but no counseling done, no understanding about what's going to happen to these patients. And these patients do require post-chemo RPLND, a challenging operation, primary or secondary, that you can get only when you have a proper training within this subspecialty and having spent at least a year and a half or 2 years within this specialty. A lot of people do TURBT. That doesn't make you urological oncologist. You need to learn proper techniques of a cystectomy. It's not only one, see one, do one, but I think this is extremely important when you take new bladders or various pouches within the cystectomy and even for upper tract urothelial carcinoma. What this specialty also gives you, it gives you an entry or gate to the doyens in this kind of specialty. I'm sure you all know those people here, Richard Hartman, Mark Soloway. From experience, I can tell you, more you focus within one specialty, you get into the network of these people and your horizon also expands. Also true for a prostate cancer. I've seen many people call themselves as robotic urologists or laparoscopic urologist oncologists, but how many have understood the science of prostate cancer and you take it further? Same holds true for these common malignancies like penile cancer. How many of you can give a proper care for a penile cancer? Same holds true for children with Wilms tumor, complex bilateral Wilms tumor. So my philosophy is, I think moving with the science and the technology and keeping ahead of the times, so it appears to be a necessity to move with the times and then take the specialty further to deliver the best care itself. To take it further, I'm sure you all know Dr. Mahul Amin. Now we are sort of geared up doing more of a precision oncology and genomics in the cancer. And I'm sure you all know my fascination for pheochromocytomas and adrenal tumors. And recently we formed a foundation which is called as a PheoPara Foundation with Dr. Nalini Shah, who's a professor emeritus from KM Hospital. And the first foundation has been formed, first meeting we had just about a few months ago. And we are trying to learn the genetics in the pheochromocytoma. This all can be achieved if you have a team which can support your specialty within the subspecialty, spend enough time for a training, and also enough networking within the specialty itself. And I must say, there is a word of caution. Technology is not synonymous with specialty, and the common example is robotic urologists calling themselves as urological oncologists and not delivering anything more than doing sort of nephrectomies and adrenalectomies. I'll just end by giving a few of my sort of glimpses from my experience. I started my career because this is a youth conclave and this is something inspiration for the young generation. My journey started in '89. Thanks to Dr. Fadke, after sort of finishing in Bombay Hospital, sent me to the Bedford Hospital for my urology training. And this was first training where I worked in Bombay Hospital, in Bedford Hospital, James Hatfield here. Then this is, all those people, you must have heard about, Charles, Rob Charles, who actually wrote the books on textbook of urology and general surgery itself. This is Nick Waterfall. So all these people actually helped me in doing more and more of a subspecialty within the urology, that is urological oncology, where I did my thesis in institute also. We brought back to India, and Dr. Desai kindly invited me to Nadiad itself. And apart from Bombay Hospital, Nadiad is another example where there are specialties within the subspecialties itself. And you can see Dr. Bapat here, and you see the young guys who have now become consultants at MPUH. Maybe the Arvind is sitting somewhere in that corner itself. So the journey from so many years, 1989 to 2024, gives you glory, only when you think it is necessary to get trained within the subspecialty and stick to this specialty. Dr. Phadke always believed that you dream, it is subspecialty, it is necessary of that particular time or in near future, that gives you glory. And this is a picture which is taken in my hospital when Dr. Phadke came and Dr. Desai came. So it's tribute to both of them who have encouraged subspecialty within the urology itself. Thank you very much. And I must end my talk in saying this specialty, which is bigger, which will give you sort of your name, is not your name which gives you a specialty. Thank you very much. Thank you, Abhishek, and thank you, Ashwin.
Thank you so much, sir. It was a fantastic and wonderful overview of the entire journey which you had since 1989.